Greetings, everyone, and welcome to another episode of Bro Doc Talk. We're happy to have our guest here today, but we'll go ahead and get started with introductions first. So, again, I'm Henry Lewis. I am a residency program coordinator and former pre-health advisor.
Hi, everyone. It's our last episode of the year, or if you're watching this now, it might be the beginning of 2024. I'm Dr. Omar Young. I'm a maternal fetal medicine physician and lifelong educator at heart, and I will let Henry introduce our guest.
Yes. So today we have Dr. Phillip Duncan, who is an experienced, renowned physician here in Richmond, Virginia. And he's going to give us a little bit more about his background, his journey, and maybe some advice to the listeners. So, Dr. Duncan, please tell us a little bit about yourself, introduce yourself. We know that you're a cardiologist, but there's so much more to you. So, just briefly give us a little bit about your background.
Well, I can say that I'm a cardiologist more or less by default. I'm currently an associate professor of medicine at VCU, but I've been in private practice of cardiology for a number of years. Actually started in 1983 here in Richmond. So I've been doing this for quite a while. So I appreciate the next generation of docs inviting me to take part in this type of program. As I said, I'm somebody who didn't really plan on doing medicine in the beginning. My goal in life was to be a high school science teacher, and I had a high school guidance counselor that helped to convince me that maybe I should consider medicine. And so I really, when I look at anything I've done and any achievements I've made, I realize I have so many people to be thankful for, thankful to, mentors along the way that helped to lead me to this. Even going into medicine, my first thought was I was going to be a pediatrician. That was what I went into medical school planning to do, and then briefly fell in love with OBGYN, but had the benefit of two cardiologists who were just tremendous mentors, and I worked with them, worked for them, and that really directed the remainder of my career, and that's why I'm doing what I'm doing. Deeper background is I tell folks that I was born in New York, born in Harlem, grew up in the Bronx. So born in Harlem, raised in the Bronx with deep roots in Jamaica, West Indies. That's where both my parents were from. That's where they shipped me off for the summers to try and keep me out of trouble.
Dr. Duncan, so before you were trying to decide on specialty and things like that, what was it about your journey and your experience to becoming a doctor that said, yes, medicine is what I want to do with my life? What solidified that for you?
Well, again, like I say, my journey was maybe different than many in that that was not my first thought. And that's why I say mentorship and people who can help to shepherd you are so important. When my guidance counselor talked to me about medicine as a junior in high school, at the time I had picked up a part-time job doing a summer program working as a histology tech in a hospital. So that's how I was introduced to hospitals and hospital work. But when she first said, well, what are you going to do? And I said, well, I want to be a teacher, but I'm not sure when I want to do that. And, right now I have a job, and really what I want to move out of my parents' house, get a Cougar XR7, and I already have a job making $6 an hour. So that was the world to me. And she said, well, have you thought about medicine? Have you thought about becoming a doctor? I said, it's going to take too long. And her exact words to me were, we're going to make it not take as long for you. And so I would say that probably only thing really positive that I did was to listen, uh, to take advantage of opportunities that were laid before me, and then try and step up to the task when the task came. But as I say, I'm not somebody who wanted to be a doctor all along. As many are, so many of my colleagues are, but I was trained to listen to my seniors and adults, and respect those who had more experience than I did at the time.
When you were then contemplating being a physician and that fire was lit in you, did you have anything in your journey that told you that you shouldn't be doing this or tried to discourage you from doing that? And how did you deal with that?
Oh, absolutely. When I got into college, that's where the first time that I dealt with folks who truly questioned my abilities, questioned my reasons for being. I think the first time I really had an issue was with a physics professor who took a physics exam, and I just managed a passing grade on it. But in college, most of your physics exams are like there's three questions, and so two of them I had done correctly. The third one I got the math wrong, and he didn't give me any credit for it. And I talked to him about it, and I said, well, that's not right. That's not the way you should grade it. He got upset and said, well, you should be happy. At least you passed. He told me what percentage of the class didn't pass, and I was like, I said, I don't care. So I went to another one of my mentors, Dr. Paul Zuber, who was the dean of urban environmental studies, African American lawyer, who actually ran against Goldwater in the, I forget what year, primary for the Republican Party. But anyway, Zub called the chairman of the Department of Physics, said go talk to him. I went to talk to him, and he said, well, I don't want to go against my faculty, but go back and talk to him because I agree with you. You deserve a higher grade than this. And I went back, and he was just totally pissed, but ultimately gave me a higher grade. And that's when I went back to the office to the physics office and transferred my to another class because I realized we weren't going to get along. But this idea that being Black, I should accept passing as enough. That whole concept of low expectations is something that I was fortunate growing up in New York, going to school where I did. I'd never had to deal with that, and so that was the first time. But then it happened, again and again throughout my career. In college, similar issue with my faculty advisor, who I wanted to take an extra 3 credits one semester, and he didn't want me to. So we got into a little thing, and he said something to the effect of sort of suggesting that I should be happy that I was there. And so I asked him, I said, well, am I the least qualified student in this particular pre-med program? It was actually a biomed program. And he said, no. I said, all right, then I'm going to take my class. And I switched my major to biomedical engineering. Fortunately, I still entered medical school early, and that experience led me to Howard. So I went to medical school at Howard, and I can say that it was a respite, because in my career, that was a time when, again, it was challenging. Medical school was challenging for everybody, but I never felt challenged because of who I was or what I looked like. And coming out of that in residency, sort of back to the same old stuff, constantly having to fight for things. Even my fellowship, there were several residents that were chosen. I wasn't chosen. I had to fight with the department to get my fellowship. I said, okay, if I'm the least qualified out of the three of us that wanted this fellowship, then let me know. Then I can accept not being chosen. But if I'm not, then you have to explain to me why. You know, in later years, someone shared with me something that, most people that we run across who may do things that we don't think are quite right, that we think are racist activities, are not racists. And so I don't like to challenge anybody with the concept of, whether they're racist or not, but I will challenge racism. And if there's a behavior, folks do something, I think it's reasonable to challenge people. Well, why are you doing this? What's your criteria? How have you decided that this is the right way to go? And let them explain that. Because if you just call someone a racist or say this is racism, then they'll just say to you, "Oh no, I'm not a racist," and they'll tell you about their black friends. Um, but but I found it became helpful to challenge what are people doing and why, and having them explain the rationale behind that. And at times it would change views, sometimes it wouldn't.
Does that have anything to do with your background? I think it's a quote on your background, which I think is quite impressive. Um,
Absolutely. Absolutely. It is.
so, oh, sorry, go ahead.
No, it's all about what your argument is. It's all about improving your argument.
Right, when we call people racist, and you automatically shut people down because they're going to be quote unquote offended. But when you challenge people on exactly what their reasoning is and why they're thinking what they're thinking, and then they have to come to a different conclusion, I think is much more powerful in the long run. But it is exhausting for folks like us in medicine. So, but I appreciate your experience. Um, Given what you have gone through and where you've come to now, can you tell our listeners what makes a good mentor for you and what shaped mentorship for you to become who you are?
So, so a good mentor is willing to give you time and listen to you. That's number one. A good mentor is someone who's going to be honest with you. And beyond that, folks can say and do things in all kinds of different ways. But someone who's willing to sit down and talk with you, get an idea of what is you're about, what you're thinking, where you are, where you want to go, if you have a direction or not. I think that's important. And then someone who be able to be honest with you and tell you that, hey, okay, here's what you need to get here. If you've got a 2.8 and you still want to go to medical school, someone will be honest and say, okay, 2.8's not going to get you there. But if this is really what you want, if this is your passion and you're willing to put the work in, then you do a master's level program or post-bac training to bring things up, if this is what you truly want to do. And also be honest in terms of finding out if this is what someone truly wants to do. Because no matter what we do, we want to do it to our best, and do our best is going to be challenging. So I think you have to be committed to the journey.
And what did that look like for you? And you mentioned you had someone in high school that kind of encouraged you to go into medicine. Was there an extensive kind of mentoring relationship with that person, or did you have others kind of along the way?
Well, there were many along the way. You know, I would say that I got introduced to medicine by a doctor who ultimately became my colleague, Dr. Alfonso Johnson, who was a cardiologist at Albert Einstein Hospital in New York. I didn't even know him at the time, but he's a person who developed this medical program that I was involved in the high school biocareers program. And my guidance counselor, Yetta Cohen, is the one who thought that I would be a good fit for that program and led me that way. She didn't have many words, like I say. The things she said were few, but they were impactful. I think about when I went to college. Paul Zuber, Senior, he was somebody who was very, very old school. Back in the day, while back, we used to sit up in his house. He had a few of us that he decided he was going to mentor. So he'd invite us over his house. We'd sit over his dinner table, and he'd tell all the stories about politics and law and his involvement with the 1954 Brown versus Board of Education, and he was a chain smoker, chain drinker. He put a bottle of scotch in front of him and ice and a pack of cigarettes, and he'd sip and talk and smoke, and we'd be there for hours just fascinated by his stories. But he was very much about telling us the truth and sort of keeping us straight. I mean, there were times in college when, I don't know, he had spies everywhere. It seemed like he knew who I was going out with, and gave me advice with things like that. But he didn't pull any punches. He knew if my grades were not where they needed to be, and he'd send a message usually, because we didn't have cell phones back in the day, but I'd get a message from one of my classmates or actually one of his grad students who was my girlfriend at the time. Dr. Zuber wants to see you. And I knew that he was going to tell me, look, you got to straighten up. You want to do this. Here's what you have to do if you really want to go into medical school. And he was very upfront about it. And, I say I can go through my mentors. I think about Boise Barnes and David Williams in DC, with a cardiologist that I mentored under. I worked in their office, and Boise would always pimp me. I mean, he just peppered me with questions as a student, just challenging me constantly. It's like I say, there are a number of folks along the way. And the one thing that they all did, they all came with honesty, integrity. They were concerned, they were willing to listen, and they all came with the truth.
I love that, especially the end, the truth, because that's what you need to hear. So, switching gears a little bit, tell us a little bit about highlights in your career, highlights in the field of cardiology. The good, the bad, the ugly, all of it.
So, wow, it's amazing because it's been a long journey. It's been a wonderful journey, and then there are parts of it that I think I'm still concerned about. Like I said, I've been in practice for 40 years, but I started medical school in 1974. So many things were very, very different back then than they are now. I tell folks I'm training that no matter what you think you know today, 5 years from now, at least 20% of it will not be true. Sometimes even more than that. It's going to change. So I've seen tremendous, technological changes. I've seen, I was in training at the beginning of things like coronary care units. I was involved, early at the end of my fellowship when we were just starting to do things invasively during heart attacks, given thrombolytics and clot busting agents. Doing balloon angioplasty was something that sort of came into being just as I was starting practice. I used to put pacemakers in, so having putting in pacemakers that were as big as a hockey puck and a half. Now these little tiny things that even stuff like that we can put directly in the heart that's the size of a pill. So I've seen all these things occur, tremendous therapies for high blood pressure, high cholesterol that weren't available back then. Tremendous advances with respect to things like heart failure. And the one thing that I'm concerned about that, or the downside of that, is when we look at present day health outcomes, instead of getting better, in spite of all this knowledge, in spite of all this technology, we see things getting worse, or staying the same. And we see certain populations who are denied access or adequate access to some of these therapies. And that's the part that keeps me up at night. That's the part that keeps me working and wanting to continue to work at what I do, because clearly the work's not done. It'll never be done, but clearly I feel I can still play a role in seeing to it that we move this needle forward.
Why?
Oh,
Oh,
sorry.
just briefly, that made me think of a question. Thank you, Dr. Peon. Why do you think that despite all of these advances in, cardiovascular disease treatment, that things are just getting worse? Why are things getting worse, and what can we do about it?
So there's several things that I think affect our poor outcomes right now. And I would say some of them are personal, what I call, what we call social determinants of health. But others are what I call the systemic determinants of healthcare. And so, I like to talk about actually 7 things. I call it 5s plus 2. So it's food, income, village, education, and shelter, and also behavioral issues and drug abuse. So, we know a lot more now about food and what foods are healthy, and we have a lot access to a lot more foods, but we still have issues of, is it available? Because we still have areas that are food deserts. If it's available, is it affordable? And if it is there, because if you've got if you live in a certain area and Whole Foods opens up in your neighborhood, that's not necessarily going to be affordable food. But the other thing is it appealing? So I know that there are things that might be beneficial, or that I can present to some folks, that may be culturally appropriate. And other times it's not going to be culturally appropriate. So when I remember talking to a patient, and the dietitian was there with me, and I was talking about things that this patient could do for breakfast, because that's one of the big questions: what do I have for breakfast? And because traditional breakfast is going to include some kind of smoked meat, eggs, maybe biscuits, or fried potatoes of some sort. And I started talking about, I asked you had to have a blender or a NutriBullet. I talked about smoothies, and I was talking about things to put in smoothies. The dietitian talked about putting avocados in the smoothies. I know that this patient might ultimately get there, but it was not culturally contextual at the time. And so with food, you have to consider all of those things as you were making changes to improve that. Income is easy because income has to be livable. We have lots of places where it's not even about how much folks make, but is it livable? Sometimes folks who make a little bit more money may be in worse shape because they might not, be in a position where they have Medicaid, or might be able to get WIC. So understanding the impact that income has on our health is exceedingly important, and that's livable income. When I talk about village is so important because it's what's around you. What kind of support do you have? Family, friends, and are they positive or negative? So village is exceedingly important. Education, one of the things I like to talk to again the trainees about is the fact that it's not just the education of the person you're talking to, but if as a healthcare provider, we're blessed with having had a lot of training and education. And if we can't impart that to somebody by figuring out where they are and how they understand it, then it really doesn't mean anything. So it's being able to assess what's the patient's level of understanding or ability to understand, and then talk to them or communicate to them in a way that they can get the message. So that's the E. The S for shelter goes without saying. Is shelter there? Is shelter reliable? Are folks hopping from one place to another? Are they homeless or unhoused? Do they have a stable house? That's huge. I mean, Henry, that, and I'm sure you see it in North Carolina. There are times when we discharge people to the street from the hospital. You can't get good outcomes when you can't even have a place where you can send the medicine to someone. So that becomes important. And then there's unfortunately a lack of behavioral health workers and specialists everywhere in our country, and that plays such a huge role in folks' feelings about health, ability to follow health programs, and obviously drugs, including nicotine and alcohol. But drugs are a huge impediment to getting best outcomes. So that's on the side of the social in terms of health. But then there's the system issues. We have to have infrastructure, and that's both physical infrastructure as well as digital infrastructure. We have to have the people, so we have to have the human resources that we need to deliver good health care. We know that there's a shortage of folks in every aspect of delivering health care. But also, even if you have the infrastructure and the computer systems and all that stuff, we have to come up with ways to leverage our time to get the best outcome. So often you can have great people, you can have beautiful buildings, but we have folks doing so many things, maybe some of them even outside of what they would best be doing. So we take all the time away. So there's no time to interact with patients. And we're seeing that become a greater and greater problem, even in the setting of having computer systems where, you talk to patients and it's like, how much time do you actually talk to the doctor? Well, really, doctor came in and talked to me for about 3 minutes. They spent an hour and a half in the office, but and it's not because the doctor don't want to talk to them. It's because you got to read this, you got to go off to that. You're doing all these things. So we don't have that face-to-face time that actually results in your ability to work with people, gain their confidence, gain their trust, explain what you're doing, so that you can move to get the best outcomes. So those are just a few of the things. I can go on and on, so I don't want to take up all your time, but
So
That was
I
excellent.
love it. So it's great. Our health systems are not set up for prevention, and they're not set up for the success, particularly of our minoritized patients and faculty. Um, you made me think of something I do lots of cardio obstetrics, or I see lots of cardiac patients in pregnancy. And, I have lots of Black pregnant patients coming to me with really bad hypertension, really bad um, coronary artery disease, even in their reproductive age folks. Um, and so I wonder, how do we voice these concerns in deconstructing our health systems so that we actually engage the community? Like, when these health systems were created, they were not created with the intention of, listening to Bobby and Susie in the community. They were created so that universities could be sustained and supported, and then the secondary mission was to provide healthcare to communities. So I'd be curious to know, from your perspective, how do we deconstruct the current health system that you and I both work in, especially for our Black patients?
That's a tremendous question and a huge undertaking. And I would say that being realistic, we're not going to deconstruct the current system, but we will. I think it's possible to reconstruct the current system, and I say that in that there are parts of the system that still allow us and help us to do what we do. There are many parts of the system because so many decisions are made from the top down as opposed to from the bottom up that no longer, and some never did, service the concept of getting the best outcomes for our patients. The only thing or the things that we have to offer is our voices. We can't afford to be silent. We don't have to shout, so we don't have to raise our voices, but we do have to tailor and construct our arguments and be willing to speak truth to power at every opportunity, so that we can make those changes that retool and reconstruct the system that we have. And while it would be foolish for me to say, yeah, we're just going to tear it all down and create something new, because that's not going to happen. But we can influence the direction that we go. And I've been in medicine long enough to see where that has happened. So, for example, I look at where we've come with hypertension, for example. Hypertension is still a huge problem. It used to be a terrible problem, though, where people used to say a normal systolic is 120 plus your age. And through multiple iterations and many Black cardiologists, some like Jackson Wright, who used to be a VCU, Keith Ferdinand, who was instrumental in JNC 7, I believe, 7 or 8. Folks have made their voices heard in a way that we've seen those numbers come down, and we initially saw better outcomes as those numbers came down because folks realized we needed different targets. I think it was JNC 8. There was a huge disconnect between what ultimately got published and what a number of the Black cardiologists who were involved, cardiologists and pharmacologists and internal medicine specialists, what they felt was right, and ultimately that got changed. So we moved towards a different target. Because we are underrepresented, it means that we have to have outsized voices. We need to say where do we have opportunities to have our voice be heard and make sure that it's heard. It's, I think being Black in medicine, I think it just becomes one of our duties, one of the things that we just take on, we just got to do.
Agree 100%.
Dr. Duncan, you've given us some amazing gems. So what would you tell your younger self in terms of advice, and what advice do you have to listeners of this podcast?
So probably the most important thing for a younger me, I would say, stay even more connected with your mentors and folks who are trying to guide you, because while I look and I say that there are lots of opportunities that I've had that I've taken advantage of, there are a lot of others that I think are equally or were truly amazing that I just wasn't paying attention to. So I think keeping that open mind, listening to the folks around you, even the folks that you think might not have your best interests at heart, listen to those and help that to guide you moving forward. I would say that's exceedingly important. The other thing is, I think that it's important for folks going into any field in medicine to pay attention to themselves and recognize the importance of preservation of self to go forward. So being aware of their own mental health, their own physical health, their emotional state, because I think that affects you tremendously during this trajectory. And there's a reason that Black physicians die at a much earlier age than their non-Black counterpart in this country, because there's a lot of work to be done. And if we don't learn self-care, and preferably the early the better, the more difficult it will be for us to be effective going forward.
Well said. Well said. Thank you, Dr. Duncan, for being a guest on this episode of Bro Doc Talk. And for the listeners, stay tuned for another episode.
Okay, thank you. Y'all take care.